Okay, so we should be broadcasting live now at 7 o'clock, and I'm going to go ahead and get started. Just very exciting. This is the very first broadcast I've got in my brand new studio in the office. So there might be a few glitches here and there, but should be a lot of fun and have a lot of information that'll be good. And we'll go ahead and get started. This is more or less going to be an introduction to applied kinesiology. There's been issues in the past where, the amount of information that I'd love to be able to get across in a brochure just isn't going to work when you're talking about the basic 100-hour certification in applied kinesiology. So that's partly what this video is for. There's a lot of misconceptions and things about applied kinesiology that we're going to touch on. And that'll hopefully highlight some of those things and maybe why somebody would want to go down the road of studying applied kinesiology. So we'll go ahead and get started. Just to introduce myself, my name is Dr. Chris Montanaro. I've got both my diplomate in applied kinesiology and in nutrition. And we'll go ahead and jump right in. And with this first slide here, that I just wanted to cover a couple of things. I'm hoping that I'll be able to catch some of those live questions using Twitter. Now, if you've got your own Twitter account, you'll be able to sign into your account, write whatever question that you want, and then as you'll see on the screen here, at the bottom of this particular slide, it says it's got the pound sign and then applied kinesiology. And if you write it just like that with no spaces at the end of your question, it'll automatically come up in a way that I'll be able to read those questions and be able to do this in a live basis. I've also got written here my Twitter account name as well as the at AKDoctor34. So that'll hopefully allow us to be able to have a little bit of interaction if you've got some questions, because I'm definitely here to be able to do that as well. So we'll go ahead and get started. Some of these slides you'll be able to read just a little bit easier than others. Most of them, they should be pretty easy and not have too much of an issue. But, the basic question that we want to cover is, what's applied kinesiology? The basic definition of it, more or less, is the study of movement and function properly applied. And I think that's the more important piece here, is that we want to take the body and whatever moves and whatever functions, we want to make it move and function that much better. And that's ultimately what we do in applied kinesiology. We'll compare that a little bit with the dictionary, Dorland's Illustrated Medical Dictionary. If you were to use the exact same definition for chiropractic, it actually will fit very well for applied kinesiology as well. And what it says is it's a science of applied neurophysiological diagnosis based on the theory that health and disease are life processes related to the function of the nervous system. And, that sounds perfect for what we learn in chiropractic school, certainly. And we've got the irritation of the nervous system by mechanical, chemical, and those psychic, more of that spiritual thought processing, that psychic, emotional part of our being that all comes into play. And that's really the focus behind what the basis of chiropractic is, and also behind that basis of applied kinesiology. We always, in applied kinesiology, talk about the triad, where we talk about the mental, the physical, and that more biochemical side of things from that triangle perspective. So we're always going to be taking a look at it from those three different sides. And then we're going to restore the health on those different sides as well, and that's a lot of what we'll be doing. Diagnosis is the identification of these noxious irritants, and treatment is the removal by the most conservative method. And I think that's very important when we're talking about that holistic side of medicine. What's going to be the least invasive, really going along with that oath that we all take to first do no harm. We want to make sure that we're doing the least invasive things and being able to get the biggest response and the biggest help for the patient at the same time. So again, what we had said before, if it moves or if it functions, we're going to make it move and function better, which really gets to be fun because we go through school for 9 or plus years of schooling, and we learn all these really cool things in anatomy class and physiology class. But then most doctors, and it doesn't matter what type of doctor, we could be talking about MDs or DOs or chiropractors, You go through that much schooling, and then how much does the average doctor spend with a patient? A lot of times those visits aren't going to last more than 30 seconds on up to a few minutes, and it doesn't really allow us to delve deep into the knowledge that we had learned. Things that we had to memorize, all these things in gross anatomy, and then half the time we don't even use those ever again. That's part of the beauty of applied kinesiology, because we're actually going to take that information and bring it alive and actually use it in a way that we're going to be able to help our patient. And we'll give some examples of how that's going to be in a little while. AK is definitely what we would call very functionally based medicine. We're always challenging the body to be able to perform different tests that it should really be able to do very easily. Just take, for example, just a normal gait walking mechanism. Everybody knows that when your right arm goes forward, your left leg goes forward. It's just a natural gait mechanism that'll take place. Well, what if when somebody is being tested and we muscle test the right arm and the left leg in flexion both at the exact same time? Neurologically, it's supposed to be facilitated and test very strong, but what if it doesn't? Or even just simple functional tests like a grip strength, or a functional test like somebody looking at a Snellen and eye chart. You should be able to see that 20/20 vision. What if after an adjustment that maybe wasn't the best adjustment and actually stressful to the nervous system, they got worse on a Snellen and eye chart, and actually, they dropped 1 or 2 levels. All things that we want to look at. So that's what we're talking about. We've got things like Ragland's test, when we're testing blood pressure laying down and then standing up. That's the body in a functional way being able to see what's happening instead of a one-time moment in time with a blood test, which is certainly good, but is not going to give us that functional, how is the body able to react right now and handle different circumstances. So we'll be talking about things like that. And the beauty of it is that applied kinesiology is really going to challenge the body one way or another, directly or indirectly, for all the different organs and systems. And that's what we're going to be doing. The beauty of applied kinesiology also is that there's a growing number of doctors from all over the world learning applied kinesiology. And first and foremost, under that premise of, that oath that we took again, first doing no harm. And we really want to take that to heart. And that'll be coming back more and more as we talk today, and certainly as we go through the chiropractic or the applied kinesiology 100-hour course that we'll talk about. That'll be starting up in September down in Florida. I'll be teaching that towards the end of September this year, and also going to be teaching it at the very beginning of October in New York, at Seneca Falls location near New York Chiropractic College. We'll talk more about that towards the end. So one thing that's really neat is applied kinesiology is really the most inclusive and most dynamic healing system in the world from some of the best minds spanning all of healthcare. And what's really neat about that is you take most any other techniques that is taught in chiropractic college, for example, and most of those techniques are what I would call very static. They teach you the technique, and that's pretty much doesn't change very much throughout its course, throughout its history with a lot of these techniques. You may add little nuances, maybe add a little bit to the technique, but all in all, it's very static and not changing. In applied kinesiology, we have national and international meetings, from meetings of applied kinesiologists, from doctors that are PhDs, from medical doctors, chiropractors, DOs, almost anybody that you can think of that's constantly adding to the body of knowledge of applied kinesiology. If there's new information that comes out that's beneficial towards healing patients, that's what's being presented, which means that the body of applied kinesiology is just massively and exponentially growing constantly, which is great for our patients because they're the ones that really are going to benefit. It doesn't necessarily make it easy on the doctors that are needing to treat and learning all of these things, because you're constantly having to stay up on this information. But knowing that and staying up on top of it, we have our patients that they come in with more and more difficult things. They're sicker than ever before, and we've got answers to be able to do some of those things, hopefully without using drugs and surgery as the very first thing that we're looking at. we have this massive toolbox that we can pull from. And some of the genius behind applied kinesiology that we'll be talking about here is from Dr. George Goodheart. And what I want to talk about for a second is that there's a lot of misconceptions about what applied kinesiology is and what applied kinesiology is not. And first we have to think back to when Dr. Goodheart had discovered applied kinesiology and he was teaching applied kinesiology to doctors. And what happened was he wasn't this amazing entrepreneur, he wasn't this amazing businessman. So he didn't patent that term applied kinesiology, which created some issues because we have a situation where Dr. Goodheart had patients coming from all over the world really because of the results that he was getting. Amazing results. And as a result, him doing a little bit of his teaching and getting these great results, it just so happened everybody became an applied kinesiologist at this point. There wasn't this governing body and this patent that said, you had to do this, this, and this before you can call yourself an applied kinesiologist. And that's where some of the problems came. You end up getting people that become very liberal and making these weird, wild, wonderful claims saying, oh, yeah, it's applied kinesiology that they're doing. And, that partly is what gave AK some of its bad name originally. So that's some of what we want to make a distinction between is applied kinesiology that was taught by Dr. Goodheart and maybe not exactly what we would want to call the most scientific applied kinesiology that just the average person puts up on their shingle. They call themselves an applied kinesiologist and they're not really certified and trained under the kind of works that Dr. Goodheart had taught. So I just want to make those two differences there. It's very important to understand. One thing that sometimes people will say is, I'm not so sure that I believe in all that AK stuff. And my first response would be, what is it in applied kinesiology you really don't believe? Is it the anatomy, the neurology, the physiology, pathology, biochemistry, and all the works of thousands and thousands of medical doctors and DOs and MDs and all of their work that comes together? And that's really what Dr. Goodheart had done. Part of his genius was that he followed and learned from some of the best doctors in the world from all of these different disciplines and wanted to take the best of some of their information and actually put it together in a way that was usable by all the other doctors that he was teaching and in a way that he could use with his own patients and be able to see those different changes. So that was very important and something that we need to keep in mind as we move forward, that this isn't just one man's information. This is really a collection of some of the best information from all over the world, which is why that was actually his genius, was being able to collect and put that all together in a very usable way. So kind of neat where that all comes together. Now, talking about the origin of applied kinesiology, actually, Dr. Goodheart, he was a chiropractor, and back in 1964, he was using a lot of manual muscle testing, and this manual muscle testing is gold standard muscle testing. It was actually developed by Kendall and Kendall. This is used in and is the most gold standard of muscle testing throughout any medical school and chiropractic school at this point. So there shouldn't be any issues there with people. But what had happened was he had this one patient that came in this one day. He'd been a patient for quite a while. He was actually a delivery person for Standard Process and had helped this patient with a lot of things. And, he, after a particular treatment, was out in the waiting room, and there were several other patients out there. And, the patient had asked Dr. Goodheart, when are you going to finally fix my shoulder? I know you fixed this, and this, but are you going to fix my shoulder? So, Dr. Goodheart brought him back in the room, and, this patient had this horrible winging scapula, which anybody in the applied kinesiology world and understanding how muscles function is going to tell you that the muscle itself, the serratus anterior, just isn't functioning as well as it should be. And he kind of felt in there and felt these nodules on the serratus anterior really rubbed out those nodules, which was the beginning of the first technique called origin insertion technique, and literally within 10 or 15 seconds changed the function of the muscle instantly. It wasn't winging anymore. Patient can move it fully, didn't have any issues, and Dr. Goodheart thought to himself, he's like, wow, changing the function of a muscle that quickly, that's amazing. And that really kind of got things started off, and some really neat things happened at that point. With the starting of applied kinesiology, I'm going to refresh this a little bit for the Twitter account. Just being able to see if anybody is asking any questions here, so I can kind of stay up to date on that there. So, that was kind of the start of applied kinesiology, and it was the start of thousands of different techniques that were all taken into play with applied kinesiology in that basic 100-hour course. And part of the beauty that a lot of people don't really understand is we're in the middle of the Olympics right now. Dr. Goodheart was actually the first chiropractor ever to be on the Olympic board, medical board for the 1980 Olympics. And you don't get a position like that without getting incredible results with patients, and getting those results really fast. You've got a scenario where patients, these athletes, have been training their entire lives, and if you have an injury a few weeks before the Olympics, that's kind of not very lucky. But you need to get back as quickly as possible, and that was part of the beauty behind what Dr. Goodheart was doing, is getting these incredible results very quickly. And I think that's important for people to understand that that's what our patients are looking for. They want to get better as quickly as they can, and with the least invasive, first do no harm type of mentality at the same time. So it's very important to bring that up. We've talked again about applied kinesiology being the only really truly dynamic system used in the chiropractic profession, because it's constantly being added to. It's always being expanded upon. And we're not going to limit applied kinesiology just to the chiropractic profession. Yes, in America, most of the applied kinesiology doctors are chiropractors. But I had the privilege of taking my diplomate exam over in Europe when I was in Belgium. And most of the diplomates over there were actually medical doctors. So this isn't just a one profession specialty. There's certainly doctors from all over the world, from different types of doctors that are applied kinesiologists that have gone on to get their diplomate. So we've talked about Kendall and Kendall. It's the gold standard of muscle testing. And really what we're looking at in applied kinesiology, certainly we always talk about muscle testing, and that's what it's most well known for. But it's good to keep in mind that it's not just muscle testing. Some of the thought processes that go behind treating a patient that comes in with almost anything that you could think of is really the heart and soul of what applied kinesiology is. But when we are muscle testing, we're going to take a look at all of the excitatory inputs that are going into the nervous system and all of the inhibitory inputs that are going into the nervous system. And we add all those up together. What is the nervous system doing at that point? Do you have more positive? Yes, we want the muscle function to actually test strong, or we want the muscle test to be inhibited. And what is the nervous system actually doing in between all of that? There are times that we want the muscles to be weak. For example, if we're walking and our right arm is going forward, it makes sense that the flexors of the arm are going to be facilitated. That's what the body is doing. But at the same time, the lower trapezius and the lat on that side actually have to inhibit to allow me to lift up the arm. So all of those excitatory factors, again, all those inhibitory factors are always being added up and subtracted by the nervous system, which allows us to have function. And that's what we're measuring by the muscle test. That net response of all those positive and negative factors that are coming in the anterior horn of the motor neurons in our spinal cord. We learn those things in neurology, we learn them in gross anatomy, but now actually applying it in a very scientific, very reproducible way, and that's part of the beauty of using these muscle test from an applied kinesiology standpoint. It's not necessarily a muscle test that's gross muscle strength, which is where sometimes people get confused. It's not a muscle strength. It's not a disability test that you would do for a motor vehicle accident or workers' compensation purposes. This is a much more fine-tuned type of a muscle test that we're going to use in applied kinesiology. And it's very much an art, but an art that's very reproducible in a lot of ways. And even Dr. Goodheart, who was the founder of applied kinesiology, who was really the father of muscle testing, he himself said when he was treating patients, when he was teaching doctors from all over the world, don't just use muscle testing. And he always said that. And, just come off from that just a little bit when I'm teaching in school, when I'm teaching at different seminars, people will come up to me and is like, well, the muscle test is stronger, or, it didn't strengthen this and it didn't fix the problem. It's like, all right, but, I never taught that just by fixing the muscle makes the problem completely gone and that there's no issues ever again. We always want to measure other things, and that's what Dr. Goodheart always said. And please always keep it in the forefront when we're doing any type of treating of a patient, when we're doing any type of muscle testing or any other type of technique. Measure other things. For example, range of motion. If the treatment improves range of motion, you're probably doing a good thing. If you will use an inspirometer. If we improve somebody's inspirometry reading from somebody that tested as an 85-year-old woman to a 35-year-old athlete, that's a big difference. That's improved function, and we can measure that almost instantly when we're using some of these things. We can use JMAR grip strength. Somebody improves their grip strength instantly. We know we've got neurological improvements. Changes in pain, changes in blood pressure. We can change blood pressure a lot of times instantly. Ragland's test we can change very quickly. The Snellen and eye chart. There's times that I won't let a patient leave the office until we know that we've seen their vision improve, 1 or 2 or even 3 levels sometimes in a Snellen and eye chart. I've got a couple of cases, one in particular that we'll talk about towards the end, about doing just that and some of the results with it. And certainly always combining our applied kinesiology exam and testing with all of our neurologic and orthopedic tests that we always learn in school. We don't do them, in spite of all of these tests. We always do it in conjunction with it because we want to see all of those types of tests being improved. And really, most importantly, that goes along with this is when Dr. Goodheart would always tell people, if you treat the same patient over and over again, more than 3 times, and you don't get any improvements, then that's not it. You've missed the boat there. You're probably missing something. We really need to, dive in further, do other testing. We're missing something. We should be able to get results very quickly, and that's something that we should always be able to follow very closely. In applied kinesiology, we really talk about something that's called the 5 factors. I actually added in a sixth and a 7th that aren't called the original 5 factors, but they still come into play. But, if you really think about it, all of these things go into making a muscle function properly. We'll start off first. The most common and the most understood would be the nerve. Every muscle has nerve functions, so we want to improve that nervous system function, whether it's from up in the brain all the way down the spinal cord and the nerve roots and then the actual nerve that's going to supply the muscle in the first place. So, that makes sense, and we'll always want to take a look at that. Next being the neurolymphatic reflexes. So the lymphatic system, the easiest way to think of the lymphatic system is kind of being a sewer system to the body. It's kind of the body's way of getting rid of its junk. So, every muscle has its set of lymphatic tissue, lymph nodes, and ways of getting rid of lymphatic tissue and junk from the body, that sewer system kind of material. And sometimes the body will not be able to get rid of it as efficiently, and the muscles are kind of bathing in their own waste material, which neurologically and systematologically will what will happen is the body will actually shut off and inhibit when we're talking about those excitatory pathways and those inhibitory pathways. You'll have more inhibition taking place because of all of the toxic chemicals that are taking place in and around the area of the muscle on the nerve and the nerve root that are causing some of those issues. So we want to be able to clear those. Other reflexes that we look at are the neurovascular reflexes, or better put, the blood supply. Every muscle has a blood supply, and we want to improve that. Every muscle has its acupuncture meridian connector. Acupuncture has been around for over 5,000 years. It's really withstood the test of time. And, Dr. Goodheart was one of the first doctors to ever be even allowed into China. And he learned a lot, and he brought that back to the United States and incorporated a lot of that into applied kinesiology, and has tremendous benefits for what we can do in treating our patients. It's pretty phenomenal. So that those energy pathways, there's no question that they exist, that they have tremendous benefits on the patient's health, and that's something that we're going to use quite a bit in applied kinesiology. It's fascinating. It's a lot of fun. And sometimes those results are almost instant. And I'll talk about a particular case that if you didn't know acupuncture, then you never ever would have helped this particular patient. And I'll talk about why. And then we talk about the cerebral spinal fluid as that fifth factor. Now, cerebral spinal fluid is really, think about it as the nutrition to the nervous system. And we've got our, the craniosacral mechanism that absolutely pumps a little bit with the cranium itself and the sacrum. It's kind of like a pump, pumping cerebral spinal fluid. And if that pump isn't working properly, whether it's, birth trauma or problems with the sutures and the fontanelles not fusing properly, they can create massive problems. Some type of a head trauma, car accident, all sorts of things can throw that mechanism off. But think about this for a second. We can live for minutes, and even upwards of 10 or 12 minutes. I think somewhere in that range is where the world record lies for holding your breath. Some of those deep sea divers. Your heart can stop for minutes, and even during surgeries, an hour or two, maybe even more. But when it comes to your nervous system, if it stops for nanoseconds, that's all she wrote. You can't live for past that. So the nervous system and its nutrition is so incredibly important, and improving that cranial sacral mechanism, the cerebral spinal fluid flow, improving that nutrition to the nervous system is going to be really, really important for us to look at. And then above and beyond that, certainly we always talk about the triad that we mentioned earlier, the biochemical / nutritional component to our health. So we want to look at that, absolutely. And then the psychological stressors, that always comes into play. There's all sorts of branches of medicine, whether it's psychiatry, psychology, that they always come into play. And there's no question that somebody's psychology plays massive role on somebody's health. It's almost, we might have heard scenarios where patient comes into an emergency room and they seem to be under control, and they do all sorts of different testing, and just because of that testing they tell the patient, oh well, you've got cancer, and you've only got a year to live. And they were doing fine up until that point, and then all of a sudden they start going downhill very quickly. Their psychology changed. They were told that they're going to die, and that's what their psychology turns towards. It plays a very, very powerful role in our health and our well-being, and there's a lot of different techniques that we can use to certainly help a patient's psychology, removing a lot of times those emotional stressors. And that's one of the things that we learn in that 100-hour course, and how we can take those and make those changes there. So it's very important to look at. So nutrition being one of those factors that we talk about, here's kind of a breakdown of doing some nutritional testing with a patient. In applied kinesiology, we always, always, always are doing muscle testing with nutrition in the mouth, on the tongue, because we can back that up from a neurological standpoint. There's some people, like I had mentioned before, who don't follow the strict applied kinesiology as taught by Dr. Goodheart. They're holding it in their hands. Putting it on their body. They're thinking about it. They're putting it in their belly button, or they're doing whatever they're doing with it, and just not being that scientific. But when you put it in the mouth, on the tongue, it's in your nervous system instantly. And to kind of get that point across, think about taking some Tabasco sauce. You put a little bit in your mouth, and what happens? Instantly, it's in your nervous system. Your hair stands up a little bit on your arms. It's going to stand up a little bit. Your pupils, they dilate. Your breathing increases a little bit. Your lungs are expanding a little bit more. Your blood's flowing a little bit more. And that's how quickly it's in your nervous system, which is why we can muscle test it. Ultimately, it's going to go two different directions. It's going to go to your thalamus and the cortex, your postcentral gyrus, to the insula for taste sensation. So that's one direction it can go. And then it could also split off in a different direction towards the hypothalamus, and ultimately through a long pathway that's written here. It's going to go to the alpha motor neurons and then to the muscles, or the autonomic nervous system. So that's where we can ultimately test the differences in the muscles instantly. And this has been proven and tested over and over and over again. It's a part of peer-reviewed literature now. It's very reproducible. And that's why, especially when I'm teaching in a forum of medical doctors and PhDs and people that really want that information to be as scientific as possible, peer-reviewed research type of information, that we want to make sure that when we talk about nutrition, that we're using this from as scientific area as we possibly can, and researched as well as it can be. Understanding physiology a little bit, we'll take the work of somebody who's very well known in the world of the adrenal system. Physiological stress is Hans Selye. And one of the things that he is most well known for is the general adaptation syndrome. So we take Reglin's test, and we want to understand, it's very well known. We learn it in all medical schools. We learn it in chiropractic school, and almost nobody uses it, but it's incredibly important. And its whole purpose is for measuring, one, how the body functions, which is what applied kinesiology is, how the body's functioning in time right now, and it's measuring the adrenal glands. It's taught that way in school, but we never really understand or ask, well, how is taking somebody's blood pressure, laying down and then standing up, an adrenal test? Well, why is that? What is the functioning behind it? And why would we want to use that type of a test? And really what's going to happen is the adrenal gland, as we know, makes cortisol in the adrenal cortex, and it also makes epinephrine in the adrenal medulla. Well, when you get cortisol, will increase the effects of epinephrine, which causes peripheral vasoconstriction, which means you're going to get this vasoconstriction taking place. And then when you go to stand up, you're going to get vasoconstriction. Blood's not going to pool in your abdomen, and it's going to get up to your head very quickly. So you don't stand up, and you're not lightheaded, and you're not dizzy, and your blood pressure is likely going to go up about 10 millimeters of mercury on the blood pressure cuff. That's what's supposed to happen. But now let's take a scenario where the blood pressure doesn't go up. It actually drops 10 millimeters of mercury because we have an adrenal gland that's not functioning very well. It's not producing the cortisol, hence it's not producing the epinephrine, and that combined symbiotic relationship where you're actually going to get increased effects of the epinephrine. So we get stress of some sort, in this case standing up or running from a tiger or dealing whatever stress it is that we're dealing with, and we get contraction of nothing taking place. We don't have that vasoconstriction taking place that's supposed to. And now we go to stand up, and blood that was supposed to not be pooling in our abdomen is pooling in our abdomen. And then we go to stand up, and we're very lightheaded, we're very dizzy. And we've got patients that come in all the time that have lightheaded, they're dizzy, and we tell them, look, this is an adrenal issue. When you go to standing up, or you've been sleeping all night long and you stand up and you're lightheaded and dizzy, and you add that in with their blood pressure medication that is forcing their blood pressure lower, and then you add in this problem with their adrenals not functioning very well that may or may not ever show up on a blood test or any type of a scan, but functionally their body is acting in a way that it's telling you, look, my adrenal glands aren't functioning very well. So, they come into us, we adjust them, we work on their nutrition for their adrenal glands and all the other techniques and things that Dr. Goodheart taught us to be able to help an adrenal gland, and we improve those pretty significantly. And that's important for us to be able to look at and make those changes. Some other things that ties in with that, think about the patient who should get some vasoconstriction of the blood vessels in and around the lungs. They're under a lot of stress for whatever reason. They're running from a tiger, or they're dealing with the stress of somebody like an asthmatic. So we're supposed to get vasoconstriction, but instead we get these lungs that are trying to breathe heavier and heavier, and these capillaries that are staying wide open. Okay, so we're breathing heavier and heavier and heavier in fluid, more or less. So that's when you're kind of getting those asthmatic type of problems. Almost like you're drowning in your own fluids. So, that's where Dr. Goodhart always said that an asthma case is always a problem with the adrenals. And he always treated it that way. And that's why he got such great results treating asthmatic patients as adrenal patients. So that's where it kind of comes into play. We learn these things. We learn Ragland's test, but we don't actually apply it. We don't think about, oh yeah, you're lightheaded, you're dizzy a little bit. Well, it's kind of the normal lightheaded and dizziness. Even my brother at one point had been having some lightheaded and dizziness. He played basketball at a very high level in college. He was actually an All-American basketball player. And, there's one point where he was having some issues, and we're in with the doctor. And I'm actually in chiropractic school at this point, having just learned Ragland's test and tested it on my brother, and he had dropped. And, I kind of had an idea of what I thought that meant, brought it up with the doctor in the doctor's office, and, told him about doing Ragland's test. He's like, oh, yeah, let me test it. So he tested it. He's laying down, take the blood pressure. Had my brother stand up, and then, probably 5 minutes later after we've been talking, retook the blood pressure while the patient, my brother in this case, was standing up. And that wasn't a very quick neurological function very quickly. It wasn't happening, real time. So at this point, the body had already adapted and can handle it. And every time I had tested it, it had dropped a certain percentage that was well beyond what would have been considered normal. And, that was an adrenal case that we had to treat much differently, but what didn't show up, and the doctor in that case didn't even, wasn't able to pick up on it. In another seminar that I had been at, a doctor was talking about Ragland's test, and there was actually a doctor there who had learned from Dr. Ragland. And he got up and was telling a story about a particular patient who had come into his office, tested Ragland's test on every single patient that had walked in the door like he always does. And on this particular patient had dropped something like 60 or 70 points. And at this point, he's done the test long enough. He said, do you want me to take you? Are we calling the ambulance, or how are we going to get you to the emergency room? And, the patient ended up in the emergency room. Just fully knowing, the doctor knowing that the patient was in a crisis situation for your adrenals not to be functioning and having it in that poor of a situation, dropping 70 points. So, they ran every test in the emergency room that they could do. They, all the different tests and scans and blood work and everything looked fine. And they were going to send the patient home. And the doctor said, I don't care what you do. Keep the patient there. This patient is, has an impending cardiovascular incident of some sort or another. And they, kind of, whatever scenario, but they kept him there. And that night had a massive, massive heart attack. And luckily he was in the hospital and they could deal with it. That's even just one test like that we talk about it a lot in applied kinesiology, and the adrenal glands come up a lot as far as things that we're going to be testing. It goes well above and beyond what we can test in standard testing that we're going to do in a medical doctor's office or an emergency room's office where we get the typical blood work. Blood work is great, don't get me wrong, but it's not great right now functioning of the body blood work. The body goes through too many lengths to try to keep the blood and all of its other systems in homeostatic function as perfect as it can be. By the time something shows up in the blood, you've got problems. Think, for example, if a liver was so sick and so diseased that finally the cells were dying and the cells were breaking open and its contents end up in the bloodstream. Now you've got a scenario where you take blood work and you can actually measure your liver enzymes in the blood. Well, that's not the time you want to find out that your liver's having a problem. You want to find out well before then. So that's kind of what I mean about finding out things from a functional perspective. That patient that comes in, you're like, yeah, I'm tired all the time. I don't really feel so hot. But their doctor says, no, your blood work's fine. Your whatever other panels, your x-rays maybe that you've had done, an MRI, your whatever they end up running, said, no, everything's fine. You look perfect. But from a functional perspective, they aren't perfect. They're not feeling as well. And then they're told, well, maybe it's just some stress, get some rest. Maybe you're having some psychological issues and you need to go see a psychologist or some type of a counselor to talk to that type of a person and deal with issues because it must be in your head at that point. And it's not, but it just hasn't shown up in their testing, which is where functional testing comes in. We can save people's lives before they even know that they need to be saved. So very important to keep in mind there. The other things that are going to be happening with adrenal issues is you're going to have altered heart function. You'll get a spike a lot of times of that S2 heartbeat. We can see that. You can listen to it and using the stethoscope. I use the acoustic cardiograph, and you can actually physically see the heartbeat on a graph and see what's happening. And you can see adrenal problems showing right up in the heart function itself, which is very neat to see. You'll see lowered adaptability. I use a heart rate variability test in the office. Cardiologists and neurologists will use heart rate variability. A lot of nutrition doctors and doctors who will often use testing like that for all sorts of different purposes. Let me just adjust my camera here just for a second. When they're using those different types of testing for heart rate variability, chiropractors will use them. We've got basically think of your nervous system and your ability to adapt to situations, kind of like I like to bring up the picture of like being on the Titanic. You got people here who they end up in the water. Some people live for 2 minutes. Other people, they're swimming around in that cold, freezing water for 25 or 30 minutes. You've got those people that, that 25 or 30 minutes, they're much healthier. They can adapt to the stresses, the cold, much better than the people who lived only 30 seconds or a minute or two. And those people technically would be much healthier. So we want to improve people's adaptability. They could handle more and more stresses without it really affecting them. And that's part of our job as doctors, to improve that adaptability for those patients. As adrenal function goes down and you can't handle all that stress, then the adrenal glands, it's almost like going up to the thyroid and turning down the engine. So now everything's just a little bit more depressed. Your energy comes down. You're a little bit colder. You're gaining weight a little bit easier. Everything's just a little bit more suppressed. Not because you necessarily have a primary thyroid issue, but you certainly have a secondary thyroid issue. A lot of times because your adrenal glands just are not functioning very well. And it's easy to understand that, but when you get into the deep biochemistry and physiology behind it, you're dealing with all this stress. And what are you making? You're making a lot of epinephrine and norepinephrine. Well, if you back up that pathway of making epinephrine and norepinephrine, one of the things in that pathway is one of our amino acids called tyrosine. And if we're eating up a lot of our tyrosine to make epinephrine and norepinephrine, Well, guess where tyrosine's not going? We need tyrosine to be making our thyroxine, our T3 and our T4. And if we're making it to deal with stress, we're not making T3 and T4, which means our temperature is going down, our our metabolism's decreasing, and all of those hypothyroid type cases. This I'm talking about it very, very briefly. We get into it at much more depth, the biochemistry and the neurology and physiology behind what's happening. But we learn in school some of the biochemistry and the physiology that goes behind these situations, but we don't learn, okay, so we make epinephrine. Great, we can deal with a stressful situation. But what are the nuances and the differences? What happens at all the different levels between the 10 different steps it goes to make epinephrine and norepinephrine? What does it take to even get there? We never even really delve into it that deeply to understand the ramifications of, okay, well, what if this step doesn't happen? And why wouldn't that step happen? And that's what we start applying in applied kinesiology and really understanding those differences to ultimately see those types of patients and help the patients that have been to sometimes dozens of other doctors who weren't helped anywhere else. And a lot of these doctors could be some of the best doctors in the world. But if you didn't look at it in a certain point of view or a certain way, then you certainly could miss things. Even excellent doctors will miss things. But that's where we want to add to our tool bag constantly learning. I think one of the biggest tragedies that doctors have themselves is that they a lot of times come out of school and they kind of mistakenly think that they know most of what they need to know. And some of the doctors who go and they continue on and they study every single day, sometimes 2 to 15, sometimes 20 or more hours a week they devote to studying and staying up on top of things. They realize later on that when they look back, when they came out of school, they're like, wow, I didn't even know anything. I probably shouldn't even be treating patients with what I learned just coming out of school. It's kind of scary when you look at it from that perspective. So it's very important, regardless of what your background is coming out of school as a doctor, to constantly be adding to your tool bag, constantly improving your understanding of the biochemistry and the neurology, and using all these things that we learned in school and being able to help our patients. And whether you do it in your office or not, at least you'll understand, okay, I understand the biochemistry and the physiology. I don't treat that and do that necessarily in my office, but I'm going to send them to the right person who does, because this is very much what this particular patient needs. So that's important to understand. Okay. So without beating that too much to death, the body always speaks volumes, and that's where I think applied kinesiology is the most fun, is you're kind of learning a new language. This is where the patient comes in, like I had mentioned before, and they're saying, yeah, I don't feel so good. And no standard tests show anything. But you got to look at the body and what it's doing. The body comes in and the patient's kind of slumped over and they're yawning all the time, and they're just they got their head down, and they look depressed. They don't have any energy about them. And you get their history, and just everything's not very going very well in their body. They're getting sick a little bit more often, things like that. We have to understand that the body is really programmed for survival, and the body will compensate to keep you alive. To draw an image for you, you could have a scenario where a person's half naked for whatever reason, that they would be half naked and sitting on an igloo. They're on some piece of ice somewhere up in the Antarctic, and what's going to happen? The body, in a very smart way, is going to take blood from the extremities and bring it to the core to keep yourself warm. Your body doesn't care at this point about keeping your fingers. You might lose a finger or two, but it's going to keep your body alive as long as it possibly can. And that's the intelligence of the body. And it'll always try to do that. And that's where sometimes Western medicine doesn't look at the body as being very intelligent. They're like, oh, well, the temperature is going down in the extremities. Let me just give you this medication that forces your extremities to get warmer. It's It's like, well, no, the body is doing what it's doing for a reason. Hopefully long enough for you to, get the idea to get off the piece of ice that you're sitting on. Okay, it's kind of a bad analogy, but you kind of get the idea. The same idea, we could maybe make that correlation with blood pressure. You have a scenario where person's blood pressure is up, and now goes into one doctor's office and they say, oh, well, your numbers are off, your blood pressure is up too high, so I'm going to give you this medication and force your blood pressure down. It's like, okay, well, maybe or maybe not. That may not be the best or smartest thing to do at that point. If we go under the premise that the body is smart and knows what it's doing, why would it want to do that? Maybe the extra 100 pounds overweight that the patient is, the extra several thousand miles of capillaries to pump blood through, any physics professor is going to tell you the pump has to pump harder. Okay? So the pump starts pumping harder. Well, why? Why would the body think that that's smart? Well, all of that extra mileage to pump through, it wants to get some blood and nutrition and oxygen to the brain. So it does, and it's worth it to the body. It sees that it's worth a little extra damage to the endothelial lining of the blood vessels themselves. It's worth any extra damage and stress on the body to increase the blood pressure, to get some extra oxygen and blood going to the brain. But no, we look in Western medicine at the cadaver, and you open up the cadaver and you open up the arteries and you look and like, oh, well, look, cholesterol, it's bad. We don't like cholesterol. Well, what if all of the cholesterol that was there, the body was thinking, well, I could bleed to death because of all the inflammation and all of the sugar and insulin that have literally raked practically holes in the lining of my arteries. And so I don't bleed to death. Maybe I'll patch it with some cholesterol and protect myself. And that's what the body does. So now, after a constant barrage of raking the lining of the arteries and the body healing it so you don't bleed to death, doing that over and over and over again, the artery walls get narrower and narrower and narrower. Not because the body is stupid and doesn't know what it's doing. It's actually protecting you. But no, we're going to give you plenty of blood thinners. We're going to give you cholesterol medications, your statin medications, to shut down cholesterol production. And, that's playing with your body knew what it's doing. It's trying to keep you alive. It's not really fixing the ultimate problem. Yes, cholesterol numbers will go down, and you're more or less just treating a number, and you could end up, in the grave with, great numbers. Yeah, I know he's dead, but his cholesterol was 180, so we're happy with that. I'd be a little facetious, but we always want to look at the body as being incredibly intelligent and doing what it does for a reason. If it raised its blood pressure, let's ask why. If it raised its cholesterol levels, maybe there's a reason for that. We don't necessarily always have to lower a cholesterol number. Cholesterol is used all over the body. If you go back to physiology, you look in Guyton's textbook of medical physiology, taught in every medical school. You look at it, and where's cholesterol used? It's used in, every hormone in your entire body. Sounds pretty important. It's cholesterol in that bilipid layer of every single cell in our entire body is utilized. So, that sounds pretty important. And then we take into account, because of every single cell in the body, every system, every function that's taking place in the body. And that's just so important. And then we're going to start shutting down cholesterol function. It's just, you're playing with fire, and we don't really understand all of the ramifications. What we do understand is that by blocking that HMG-CoA reductase, we'll talk about it in class. We'll get into some depth in understanding some of the differences here. But by blocking HMG-CoA reductase, you're also blocking coenzyme Q10, which is intimately involved in all muscle function, especially heart. Probably not the best thing. Also intimately involved with shutting down some genetic protein formation that's taking place with the dolichols. probably not the best thing to be happening there either. So even though we start treating some of these numbers and forcing numbers to be down, we definitely have a lot of negative side effects that take place. So certainly going back to the doing no harm, doing things as least invasive as possible, and that's where we come into play doing those types of things that we learn in applied kinesiology, that we learn in any type of a holistic practice in general. So I wanted to talk about a few different case studies of some patients that have been in the office, just to kind of get the idea of some of the things that you may see in your offices. Now, one thing that I want to kind of stress here is that, I wanted to make sure when I got into practice that I just didn't treat this, I'm a chiropractor. I didn't want to treat the same old neck pain, back pain, the patient's coming in with something like that every single patient every day for the rest of my life. I spent 9 years worth of school, much more than that now, getting my diploma in AK in nutrition. And, I didn't want that to go to waste. So many doctors these days, they go to school for all these years and they spend 30 seconds with a patient doing the exact same thing with every patient that walks in the office. And I'm not just picking on chiropractors or just picking on medical doctors, but, you give the same, 7 adjustments to a patient that walk in the door and you spend 30 seconds with them. Is that being a doctor? And I'd kind of argue no, that's being a good technician. You can get reproducible adjustments and you do that over and over again, but not much thinking is taking place there. Or not to just pick on chiropractors, and you get the same medical doctor who, a migraine comes walking in the door, and you give them the exact same medication for every single migraine case that walks in the door. Or, the same prescription for whatever case that ends up walking in the door. Not necessarily being a doctor. You're kind of a technician. You're writing the same script over and over and over again. You kind of lose that processing of being able to think. And I'll give you a couple of examples. First one here, I had an OBGYN who had come into one of my courses, and she, loved the course. She's like, wow, I can't even believe, the amount of information that's in here. And, frankly, I have to go back. She told me this. She says, I need to go back and study some of this anatomy. And I'm thinking to myself, it just happened that we were talking a lot about the low back in that particular area, and having a medical doctor and an applied kinesiology course, I was hoping that her course that she was being first shown applied kinesiology to, that it wasn't going to be just stuff on the low back, because you want to be able to open the scope and realize that there's a lot more to it than just low back related things. But anyway, she wanted to go back and study some of the anatomy. And it got me thinking. I was like, this patient, this person, this doctor is a surgeon, cuts people open for a living, and needs to go back and review very basic anatomy. And it's not to pick on this doctor at all. Her anatomy that she works on as an OBGYN is in a very specific area. And she does that every single day for years and years and years. And, it's certainly understandable. You forget about certain areas, but that's where some things come into play. And this particular doctor had enough appreciation and enough understanding of what I had taught and some of my specialty in applied kinesiology that she ended up referring me a patient that she had been struggling with for a couple of years. And this patient came in with a diagnosis of desquamative inflammatory vaginitis. For anybody who doesn't know what that is, when the patient came in the office, she described it as absolutely incredible pain to the point of more or less, you just can't even have underwear on because it's so painful. Okay, so you can kind of get the idea of the amount of pain that this patient's in, the kind of physical relationship that her and her husband were having at this point, and being treated this way, for a couple of years. Massive amounts of discharge, and always dealing with that. And the treatment up to this point was almost every type of steroid, cream, antibiotic, anything that you could think of to throw at it, they did, and it didn't help at all. So I'm like, great. I want to impress this OBGYN. Hopefully she'll refer some other patients. But the first patient that she refers me is a patient that, legally and ethically, I can't really see the problem. I can't touch the area, and I'm supposed to help this patient. So we do the first thing that we can do, and we get a good history. And even just getting the history, it kind of started putting some pieces to the puzzle together for me. And so as I'm going through that, normally as I'm talking about this case study, I've got a group of other doctors in the audience or other students, and I try to get an idea of what they think. Well, going through any history that I normally do, I was asking about how often, frequently the patient goes to the bathroom. And she's like, well, honestly, pretty regularly, about every 10 to 14 days. I'm like, are you serious? Every 10 to 14 days? Like, that's horrible. And it got me thinking, it's like, okay, well, is it possible? Why would the body possibly want to get all this discharge, infection, and pain, all that kind of stuff going through this particular, orifice of the body? And it got me thinking, I was like, okay, well, she's not going to the bathroom, and it's not going through an orifice that's, very short distance away from the vaginal opening. It's like, is it possible that the body, in all of its attempts to excrete, is trying to do that in, a little bit different area? It's like, that's interesting to think about. And maybe it was. I didn't know at this point. I'd always been taught if you're not, going to the bathroom very well, that, part of the detox mechanism, instead of ending up in the toilet, that a lot of times you'll end up seeing a lot of skin issues, because your skin is one of the largest excretory organs in your body. So maybe they'll have, rashes or acne, some type of dermatitis, any type of a skin type of an issue. In her case, she had some type of a general category of discharge. She wasn't discharging from one area, she was discharging from an area that she shouldn't have been. So we addressed that. We need her to go to the bathroom a lot better. And it could have been probably just about anything at this point. It could have been your simple Metamucil, could have been, in this case, we used some different herbs. We used some very strong probiotics, and, trying to help kill off some of the bad bacteria, add some of the good stuff in, a little bit of some fiber, trying to get some things moving along. We did a couple techniques in the office that we'll learn in AK, that, adjusting the ileocecal valve, helping to move some of the bowel itself. And the bowels are very mechanical in nature. The ileocecal valve is very mechanical valve. It deals with pressure and movement, so we can manipulate that a little bit. Long story short, I'm expecting, and I told her, you've had this problem for a couple of years. You've got to at least give me a few months of making some of these changes to hopefully be able to make these really big changes for you. But I think that we can. It makes sense at this point. And she was on board. She was willing to try that. And just so happened that she came in a week later, and she told me, she's like, you know what? Within 2 days, 90% of all of the pain was gone completely. It's like, well, it's impressive. That's amazing. And, within 2 weeks, all of the pain's gone, all of the discharge is gone, cleared up, didn't have any problems at that point. And it's not that I'm bringing that type of a case up to impress you. It's just to impress upon you the type of patients that'll come in. And, that was just one thought process of a patient who's been dealing with problems for a couple of years. And that's where we start really learning about these thought processes and applied kinesiology. And it doesn't matter what they come in with. And that's kind of what we'll see here. The next thing on the list is a vision case. A patient came in actually with, in this case, as a complaint, some neck and some back issues. It just so happened to be. And I go through and I'm fixing everything that I find, and I'm going through, some things with the history. I ended up doing some very, very specific adjusting of the neck. I actually did some craniosacral work as well. And I didn't actually do as thorough of a history as I should have at this point. I actually found this out a couple treatments later. I had worked on this patient 2 times, and the way that I found out I didn't get as thorough of a history as I thought that I did was that I got a call from a neuro-ophthalmologist. And this ophthalmologist calls me up and says more or less, what did you do with my patient? I was like, oh, great. What did I do? This is the last kind of a call you want to get is you did something wrong with one of this doctor's patients. He's like, no, 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 you don't understand. Me and 3 other eye doctors have been working with this patient for over 2 years now. We've tried everything we possibly can, and his basic vision was 20 over 200, and he gave me all the diopters, all of the testing that he had done from their gold standard testing that they've done for these couple of years. And he said he came into the office, we tested him, no medications in the eyes, we weren't controlling or the scenario whatsoever. Just straight out vision was 20/20. They'd never seen this patient do that. And he's like, well, what did you do? And he wanted to come to the office and for me to teach him what I did in 10 minutes with what I teach people to do in 100 hours, which it wasn't going to happen. But those are the types of results that we see when we take into account all of these MDs and PhDs and all of these learning modalities and healing modalities that we have from all over the world to be able to apply it to a patient. You fix what you find, and incredible things start to happen. I won't go through every single one of these. The piano tuner had increased her hearing quite a bit. Another one that I really like to bring up is a woman who was in a severe a motorcycle accident. And she's actually the wife of another chiropractor. So she comes into me after, the history is a 14-year history of this motorcycle accident. Absolutely shattered most of the bone in and around her ankle, and had all sorts of pins and needles and holding things together after surgery. And after 14 years, it healed as well as it was going to heal. And her describing to me was that she was in so much pain, she was very seriously considering just having it amputated. That's how much pain she was in still 14 years later. And after the doctors that she had been to, and even her own husband, who was a chiropractor, having worked on her, just still being in incredible pain. She had heard that I might be able to do something, and it was worth giving a shot at this point, so she did. And I worked on her, and then I didn't hear from her for 6 months. Kind of had forgotten about the scenario at that point. Probably just a busy practice, and I hadn't thought to call her back. Just she had this for 14 years. How much change was I really going to make in one visit anyway? Well, in that period of time, some life circumstances had come up for her and her family, and they had moved anyway. And she had called me up. She said, we had moved, and I'm coming back to town. I was wondering if you could work on me again. After 6 months, it's kind of bothering me just a little bit. It's aching a little bit now. And I'm like, whoa, hold on a second. You mean to tell me that after 6 months, it was actually feeling better and you didn't have any pain? She's like, yeah, I felt great just after that one treatment that we had. It's just starting to bother me just a little bit, and we're going to be in town. I was wondering if you work on it again. And it just goes to show, and I've just seen this countless times when a patient had been treated or had issues for 10, 20, 30, even 40 years of dealing with some type of a health problem. They come into the office and not really expecting much and basically completely getting rid of it. And again, not to impress you guys, but to impress upon you the importance of really trying to learn some of what we teach in applied kinesiology. All of the different modalities, all the different tools. All of these things taught by Dr. George Goodheart, and the beauty of what he had to teach, and really just the culmination of some of the best minds of the world, which is why I can say very easily, without boasting, without trying to sound egotistical, that I truly believe that doctors who are diplomates in applied kinesiology, doctors who have devoted their life to studying applied kinesiology, are truly some of the best doctors in the world, because that's exactly what they've done. They've studied from and are learning from some of the best doctors in the world. So I think that's really important to keep in mind. It's also important to keep in mind as we move forward in decisions and whether we're going to study applied kinesiology or not. Is my opinion would be that we want to study everything we possibly can to help our patients. We're always going to end up with patients who get more and more difficult, and they're going to expect us to have and raise our bar and our education level constantly, because I promise, once you have studied and you think you finally got it and you're helping all these people, you end up starting to get these patients to come in that get more and more difficult, and you're like, oh man, let me go study this. You read that, you go to more seminars, you're constantly adding to that repertoire to be able to help these patients, and it's a never ending battle of being able to do that. It's incredibly rewarding. You're always pushing yourself to better yourself and your knowledge, and you're helping people that are getting more and more difficult, who truly were not getting helped anywhere else. Um, so, I'm not going to go through every single one of these different cases. You kind of get the idea. I absolutely, for anybody who has questions, I'm always available through email, always available through, giving the office a call. We can certainly do that. Please feel free to come to the seminars, and being able to work on some of those kind of things, learning everything that we have to teach in the 100-hour course, because there is absolutely a lot, and we'll be able to go on from there. So a couple of things that I'll leave you with is, people in this world are absolutely sicker, and they've got more problems with obesity, cancer, diabetes, heart disease than ever before. And when we have doctors who think within their own little box and don't think outside the box, it's not working. We're getting sicker and sicker and more unhealthy. And until we get doctors that feel comfortable and want to study way outside of their box and what they already know, when we get patients who are willing to start taking some pride in their own health and taking advantage of some of the things that we have to offer, then we're going to keep going that direction. Um, it's been in newspapers, in journals all over the world, that we've failed in our health, as a healthcare system, and as people in general. So we really want to take a look at trying to work on and fix some of those things. So my question to you is this: when sick people walk in the door, are you going to have the confidence to be able to help them and follow up and be able to help explain why you're doing what you're doing? Or are you going to fall in the group of, well, it's kind of normal, or I'm not sure, that kind of stinks. Why don't you go see another doctor? And, they keep getting passed off doctor after doctor, year after year, and not really getting any help. And, from a medical doctor's perspective, I had started medical school because of some frustrations with the medical system as it is, and just giving the same old prescription, the same old surgery for every doctor or patient who walks in the door. Or from a chiropractic perspective, I am a chiropractor. You're the same old, let me just adjust you and hope that you get better. We've got to be better doctors than that. And it's not to pick on anyone in particular, again, but we've got to raise that bar, very importantly. And we want to treat people. We don't just want to treat their symptoms. We don't want to cover up their symptoms, and that's where we have that major focus on in applied kinesiology. And again, if all you have is a hammer and you're a chiropractor, all you have is the adjustment, that's all you're going to do, and you're going to miss patients being able to be helped that could have been helped elsewhere. I have another patient who had one time her parents had brought her in. She was a teenager, and she was just losing weight like crazy. She stopped wanting to eat, for about a 8-month period of time. And I'm still at this point in the history taking stage, and it just wasn't making sense. And I kept going back to what happened 8 or 9 months ago. What happened 8 or 9 months ago? And they couldn't think of a thing that made sense to them. And I just kind of was thinking in the back of my mind, I said, all right, this is going to sound completely off the wall. It's not going to make sense why I'm asking you this, but do you remember at all stubbing your toe back then? And they got like, well, yeah, well, I broke my toe. It was, yeah, kind of right around then. It's like, okay, well, which toe was it? And it happened to be the second toe in. I was like, okay, well, that happens to be the toe where the stomach meridian goes to. Think about, from an energy standpoint, if you follow acupuncture at all, or you should now, as I'm explaining this, that you disrupt the acupuncture energy meridian for the stomach itself, and how much that screwed up her ability or desire to eat, and how much weight she was losing, and becoming very unhealthy. And that's when I had talked about very early in this lecture. If you don't know something like that, that the acupuncture meridian goes to that second toe associated with the stomach, you never, ever, ever would have helped that particular patient. And that's part of the fun of applied kinesiology. But again, the massive amount of information that goes into studying applied kinesiology, it's a lifelong study, to master it. It's just as much or more than all of chiropractic or medical school put together. And it doesn't end there. Once you've learned the basics, and you've gotten from there, you're always constantly adding and learning whatever you can. So, if that's for you and you want to see more and more difficult patients, you want to have a variety of patients that come in, and not just the same old thing that you have a patient coming in like that, treating them the same way every time. You actually want to think. You want to be engaged with your patients. You want to spend some more time with your patients than just the quick 2 or 3 minutes. This type of a technique, this way of thinking, will allow you to spend more time and actually develop some really cool relationships with people, and help some scenarios that you wouldn't have helped otherwise. So that's very important to keep in mind there. So I'm going to end this particular introduction to applied kinesiology there, and I'm going to leave you there with this. On the website that you have, right below where this is, there's a link to another production that I had made. It's got more or less, it's entitled The Top 5 Reasons Why 70% of all chiropractors go out of business, they fail or quit practice. And it's a phenomenal seminar. It's not very long, it's about 15 minutes. And it's actually very neat in the production that it's done. It's not actually even done like this seminar, which is kind of neat, in the new broadcasting studio. It's very unique. You won't see it very many places, and it's almost fun enough just to watch it for the seminar sake, and not even so much for the material. But the material is very important, and it actually adds on to, instead of me teaching that here in this introduction, which I was going to do at one point to make this a 2.5 or a 1.5 or to 2 hour seminar. I'll have you watch that 15 minutes on your own. It's absolutely a blast. It's loaded with some information and some more reasons why studying applied kinesiology is, in my opinion, and in a lot of other both chiropractors and medical doctors' opinions, the most important thing that they ever did in their entire career when it came to treating patients. And some of those studies, some of their opinions are all in there, and very, very beneficial. So again, if you have any questions or thoughts, please feel free to ask me at any point in time. You're on my website, likely, the drchrisseminars.com, which has been written on this for you the entire time. On there is the information for both the Florida course and in Daytona Beach, Florida, and for Waterloo, New York. right near New York Chiropractic College. So we've got all the information, the dates right there on there for you. Again, the seminars are coming up, and the early registration date is by September 1st. And the beauty of that is certainly you save quite a bit of money. And the 100-hour course, as it is one of the less expensive courses that are offered out there, because I think that it's just that important. I want to get as many people there as possible because it's just too important for chiropractors and medical doctors and students to learn these things, to let cost be something that keeps people away from that. We've got that, but then also with early registration, it includes the free testing kit, and that's really neat. It's about an $80 value that comes for free as well. So keep those things in mind. Keep learning, regardless of whether you continue down this road and you want to learn more in applied kinesiology or any other techniques. Just please constantly be learning, study your butt off, and because it all comes down to helping our patients, and that's really the most important thing. So thank you so very much for listening in. And again, if I can help, I'm here to help in any way that I can. Thank you so much.